afternoon, everyone. Thank you for joining us for the Building Healthy Strong Communities virtual conference. This is our second session of the day, computer-based cognitive behavioral treatment for young adults diagnosed with cancer. Before we begin, I just want to go over a few housekeeping notes. If you wish to receive CEs for today's webinar, you will need to stay for the duration of the time and respond to all the poll questions you see pop up throughout the presentation. You'll see the first one momentarily. There will be time for Q&A at the end of the event, so please submit any questions you have in the Q&A box or the chat. We do encourage participation in the chat throughout today's event. We're going to wait just a few more moments to get started, so sit tight and remember to respond to the polls when you see them. I'm going to launch the first poll right now. You should see it pop up on your screen. We're just asking who is in attendance today, and feel free to also put your response in the chat if you want to elaborate a little bit more. I'll leave that up there for about another 30 seconds, and then we will get ready to introduce our speaker for today. And for anyone that might be just joining us, we're just filling out the poll, asking who is in attendance today, and feel free to put your answer in the chat if you want to as well. Share our results. So now we can see it, and all of you can see it. Looks like we've got a lot of alums here today. Fantastic. All right. So I am now going to introduce our speaker for this afternoon. It is my pleasure to introduce Dr. Anao Zhang. He is an assistant professor of social work at the University of Michigan and the clinical research director of the Adolescents and Young Adult Oncology Program at Michigan Medicine. Anao is a health and mental health intervention researcher with a primary research interest in psycho-oncology and adolescent and young adult cancer survivorship. An intervention researcher by training, he contextualizes his work using the social determinants of youth health framework and aims to develop and deliver integrated and empirically supported mental health treatment to individuals with comorbid physical and mental health conditions. And now is also an applied quantitative methodologist who uses advanced statistical methods to support his research, including meta-analysis, structural equation modeling, analyzing experimental data, causal inference, and machine learning. Clinically, Anao is a licensed clinical social worker, a member of the Academy of Certified Social Workers, and a diplomat of the Academy of Cognitive Therapy. He has over 5 years of clinical experience in various hospital settings and specializes in social-focused brief therapy and cognitive behavioral therapy. And now I pass it over to you.
Thanks, Emma, for that introduction. It's a mouthful. Good afternoon, everyone. I hope you can all hear me okay. If there's any issues, please do let me know. And Emma will also let me know. I hope you can see the full screen of my PowerPoint. And good afternoon, everyone. It's really a pleasure having the chance to share with you all some of the work that I have been working on and led in collaboration with my colleagues from both at the University of Michigan School of Social Work, as well as those from Michigan Medicine, in supporting the complex psychosocial needs among adolescents and young adults who are diagnosed with cancer. So broadly, my work intersects the field of mental behavior health intervention and psychosocial oncology. And for today's presentation, I will start with a broad overview of the psychosocial oncology field, especially focusing on health disparities among individuals diagnosed with cancer, and then zoom into my primary oncology population, the adolescent young adult population, and then transition into the delivery of mental health interventions for AYAs who are diagnosed with cancer, especially the use of technology-assisted mental health interventions. And before we start, I always remind my audience to be mindful that we are going to have a conversation related to cancer. And I'm pretty sure that we're all on the same page that one way or another, it is most likely that our lives are all impacted by cancer, and sometimes certain conversations and discussions on cancer can potentially be triggering. So just please be mindful of that and remember to take care of yourself if you need to throughout the presentation. All right, so let's maybe start the presentation with the first poll question from me. Emma had the first one. So at the United States population level, in general, how do you think that we're doing in terms of preventing cancer incidence and in treating cancer over the past decades? Are we improving both in the prevention and the treatment, or we're improving only in the incidence, only in cancer death, or we did not make any improvement in neither cancer incidence nor death rate? All right, great. So it seems like, we have a split between we're improving in both versus we improved only in cancer death rate, but not in the incidence. And based on the empirical data, the correct answer is we improved only in cancer death rate, but not in the incidence rate. And I will just lay the statistics out in the next slide. So overall, how we're doing in general when it comes to the trend of annual cancer incidence and death. The latest data we have from the Center for Disease and Control and the National Cancer Institute reported that in terms of annual rates of new cancer cases, which is the graph on the left side of the slide, the United States reported an age-adjusted rate of new cancer cases of 481.7 per 100,000 people in 1999, whereas in 2018, the age-adjusted rate of new cancer cases per 100,000 people was down to 435.8. So overall, we are doing somewhat better, but it is important to know that there was a noticeable falling trend between 2008 and 2013 with a statistically significant annual percentage change during that time period. And otherwise, the annual rate of new cancer incidence remains stable, meaning we're not necessarily making meaningful improvement in preventing cancer incidence that's including the past decade between 2013 and 2018. On the other hand, however, and in a good way, we are making relatively good progress in treating cancer. As you can see in the graph on the right side of the slides, the age-adjusted cancer death rate in the United States reduced from 200.7 per 100,000 people in 1999 to 149.2 per 100,000 in 2018. And this represented a 32% decrease from its peak back in 1991, which translates to almost 3.5 million fewer cancer deaths during these years than what would have been expected if the death rate had not been fallen. According to the American Cancer Society, the continued dropping rate of cancer death is largely because of fewer people smoking, which resulted in declines in lung and other smoke-related cancer, and in conjunction with other factors, especially advances in cancer treatment and the much improved prevention and or early detections of cancer. Another important indicator when we think about advances in cancer treatment and cancer care in general is a patient's 5-year survival rate. So as you can see in the latest data from the Journal of National Cancer Institute SEER program, each pink dot here on the slide represents the site-specific 5-year survival rate between 1970 and 1977, and each blue dot represents the site-specific 5-year survival rate between 2007 and 2013. And then an arrow pointing towards right indicates an increase in the 5-year survival rate of a specific cancer site, whereas an arrow pointing towards left indicates a decrease in the 5-year survival rate of that specific cancer site. So by and large, we see a significant improvement in the 5-year survival rate across all types of cancer, which is highlighted in the green rectangle, though the improvement differs a lot by specific cancer sites. For example, we can see significant improvement in the 5-year survival rates for prostate cancer, leukemia, and myeloma, highlighted in blue rectangles, but also see reduced 5-year survival rates for uterus and cervical cancers. It is also notable that the 5-year survival rates vary a lot by different populations, which is not shown in this figure. And let's maybe get our second question pull up. Which race and an ethnic group has the highest cancer death across all cancer diagnoses? Non-Hispanic white, non-Hispanic Black Americans, non-Hispanic API populations, or Hispanic Americans? All right. Yeah, so I think the majority of the audience does get that right? So non-Hispanic Black Americans, unfortunately, has the highest cancer death across all cancer diagnoses. So despite the overall significant improvement in cancer death rate and patients' 5-year survival rate, as we've just showed in the previous slides, cancer health disparity in certain populations is in an area in which progress has not kept pace. For example, data from the 2015 to 19 documented Black Americans have the second highest rate of cancer incidence and the highest rate of cancer death when compared with other racial and ethnic groups. Certain observed health disparities are even more pronounced with specific cancer diagnoses. And in this slide, as you can see, Black men have the highest rates of prostate cancer incidence. And other than their non-Hispanic white counterparts, the rate among Black men is 2 times or greater than any other racial and ethnic groups, which really represents a striking health disparity of this particular diagnosis among Black men. And if we look at the prostate cancer death rate, Black men have higher rates of prostate cancer with more than double the death rate than other race and ethnicities. Disparities in cancer incidence and/or death rate are also seen in low socioeconomic groups and those living in geographically isolated areas. Lack of medical coverages, barriers to early detection and screening, and an unequal access to improvements in cancer treatments may contribute to these observed differences. Previous and ongoing research have also found some underlying biological differences that may intersect with other psychosocial factors that contribute to health disparities in the cancer population. For example, if we take a look at a particular aggressive form of breast cancer, the triple negative subtype is more common among Black women than women of other racial and ethnic groups. Most strikingly, studies have found that Black women had nearly a threefold increased risk of triple negative breast cancers. And even though it is still contentious whether the significantly increased risk of triple negative breast cancer among Black women is primarily driven by psychosocial related health disparities, or it is indeed a molecularly distinct disease, latest discussions on this one of the most significant examples of racial disparities in oncology considered both the genetic predisposition of triple negative breast cancer among Black women, which is further exacerbated by various socioeconomic related disparities, such as obesity and poor access to screening and healthcare. All right, this third question from me is, what do you think is the single most important risk factor for cancer overall? Is it the use of alcohol? Is it an individual's age? Is it an individual's dietary behavior, or the use of cancer-causing substances? Well, this is an interesting one. So I think the majority goes to diet, and we have about kind of even split between age and using cancer-causing substances. So the correct answer is actually age. Age is the single most powerful or salient predictive factor or risk factor for cancer diagnosis. So among the many risk factors impacting individuals' cancer risk, age is the most significant risk factor for cancer overall, as well as for many individual cancer types. The scope of today's presentation, however, is really on a unique age cohort between 15 to 39 years old that is often referred to as the adolescent and young adult, the AYA cancer survivor population. And before we move forward, I would like just to quickly define two terms to be used for the remainder of this presentation. So in cancer, a person is considered to be a survivor from the time of diagnosis until the end of life. That is inclusive of newly diagnosed patients, patients receiving active cancer care with curative intent, and patients receiving palliative care and/or end-of-life care, as well as those individuals who have completed their curative cancer treatment and are now in the post-treatment survivorship phase. So when I refer to cancer survivor, for the purpose of this presentation, they would refer to the entire spectrum along the cancer care journey. And second, in this presentation, I align the definition of AYA, the adolescent young adult cancer population, with the National Cancer Institute definition, which refers to individuals between 15 to 39 years old. So let's start with the AYA cancer statistics in general, right? So in the United States, there were close to 90,000 new cancer cases and over 9,000 cancer deaths in the AYA age cohort in 2020. And latest data from the American Cancer Society reported close to 650,000 survivors of AYA cancer are currently living in the United States in 2021. Despite the rapid progress and the scientific understandings of cancer in AYA populations, important research gaps in etiology, basic biology, and treatment and the survivorship issues persists, partly because this age group continues to be grouped with children and or other older adults in many clinical care programs and epidemiologic studies. And even within those research in an AYE that focuses on the AYE cancer population, data often are presented in an aggregated manner, meaning we combine the 15 to 39-year-old spectrum together, and many of us know that that actually contains several developmental stages within this age cohort. And then it is worth to think about how the AYE cancer population receives the national attention in the first place, right? So about 2 decades ago, the AYE age demarcation was established as a high-risk population after data from the National Cancer Institute between 2000 and 2005, which showed a lack in an improvement in survival for patients with many forms of cancer. This means that with the same cancer diagnosis and disease progression, AYAs benefit the least from advances in cancer treatment when compared with their peers who are in the pediatric or in the older cancer population. Some notable factors that contribute to this historical gap include the age-dependent differences in disease biology of certain cancer diagnoses that are specific to the AYE population. There's a reduced rate of clinical trial enrollment and the lack of treatment standardization of the AYE population, because most of them are either treated with a pediatric protocol or the adult protocol, and there's not necessarily an AYE protocol that has been widely agreed upon. And there's also the delays in diagnosis and in receiving cancer treatment among the AYE population, which is not surprising because that is usually the stage that we would, in general, expect optimal physical health conditions. And limited access to healthcare due to a higher chance of being uninsured given the nature of AYE's developmental stages. So with the national attention to AYE cancer since the early 2000s, we have come a long way in terms of our understandings of the values, care, and the outcomes for AYEs with cancer, but there's still a lot we don't know and need to learn, especially when it comes to fulfill the unique biopsychosocial and spiritual challenges that are confronting this age population. And I will make a case soon in the presentation that in addition to the common health and mental health disparity related factors, the AYE cancer populations are additionally confronted with unique biopsychosocial and spiritual and clinical challenges that are specific or almost exclusive to this age and patient cohort. And most importantly, within the AYE age cohort, we observe striking and persistent disparities found in the 5-year relative survival rates of common cancer diagnoses in AYAs based on race and ethnicity, socioeconomic status, sexual and gender identification, and geographic location of residence, just to name a couple of the common salient health disparity determinants. So when we are considering the unique biodevelopmental challenges that are facing AYE cancer survivors, it is important to recognize, as indicated earlier, the 15 to 39 age spectrum contains 3 distinct developmental stages. They are the mid to late adolescence period, which is between 15 to 17 years old, the emergent adulthood, which is between 18 to 25, 26 years old, and the young adulthood, which is the 25, 26 to 39 years old. However, being diagnosed with cancer significantly disrupts AYA's expectation of optimal physical health and it exposes them to the premature confrontation of potentially terminal diagnosis and death. And additionally, they often experience body and an appearance change due to certain types of cancer treatment, all of which have both immediate and lifelong implications to the healthy development of those individuals who are AYAs and who are having a cancer diagnosis. And throughout the AYE cancer population's cancer journey, they are continuously confronted with multiple risk factors that are almost unique and specific to their age and disease cohort, including the invasive curative cancer treatment options and regimens that are often painful and burdensome for AYAs diagnosed with cancer, the immediate treatment symptoms and side effects, such as nausea, insomnia, and significant changes in one's appearance and other aspects of their lives, and the long-term and often irreversible impact on AYA's fertility capacity, heart or lung health, hearing or vision issues, etc., and many other issues, and the unique psychosocial challenges such as the issue of oncofertility, financial toxicity, the financial burden, and sexualities, just to name a few of those unique and common issues that are confronting the AYE cancer population. I think it's easy to say that it's easy to understand that, you know, for any AY who are diagnosed with cancer, it is not just experiencing one of these domains or one of those single symptoms, but yet the patient populations often are facing a set of complex and very demanding risk factors. And when combining all these risk factors together, all these challenges put AYAs with cancer at significantly higher risk of experiencing psychological distress, especially manifested in the forms of depression and anxiety than their healthy peers, AYAs without cancer. And because of the unique age range of the AYE cancer population, we also know that the AYAs who are diagnosed with cancer are also at significantly higher risk of psychological distress when compared to their counterparts who also have cancer but are in the pediatric age cohort or in the geriatric age cohort. So AYA age itself is also a salient risk factors in terms of psychological distress for the AYE cancer population. And we have the last polled question from me today, which is, when compared with interventions for pediatric cancer survivors, psychosocial interventions for psychological outcomes among AYE cancer survivors are they equally effective, more effective for AYE than for pediatric, less effective for AYE than for pediatric, or the evidence remains inconclusive, right? So if we think about, as social workers, when we deliver evidence-based interventions, we do want to know how effective these interventions are. All right, interesting answer, right? So we have almost a split across for all the options. I think the majority are saying more effective for AYs than for pediatric and less. Okay, interesting. So I would say the correct answer would be C or D. So, you know, me as a clinical social worker, but also a researcher, my immediate reaction when looking at this question, I started just to wonder, right? So where does the evidence lie? And so our team has published a meta-analysis in the Journal of Critical Reviews in Oncology Hematology, and we looked across 61 clinical trials of supportive psychosocial interventions for pediatric and adolescent and young adult cancer survivors. One key findings of that study, unfortunately, revealed that on average, psychosocial and supportive treatments was significantly less effective among AYA cancer survivors versus their pediatric counterparts. So when we deliver the same or similar intervention to the AYA population, the published literature evidence found that the effectiveness was reduced when compared to those interventions when being delivered to the pediatric cancer population. So grounded in that meta-analysis, but also in many other literatures, this kind of really demonstrated that even though there are efficacious mental health interventions available, including depression treatments available for AYAs in general, with or without cancer, such as the cognitive behavioral therapy, right? But when it comes to delivering research-supported treatments such as CBT to AYA cancer survivors, these interventions seemed to be not as effective as when they're being delivered to the pediatric cancer population or to the adolescent and the young adult population who are without cancer. And there are a wealth of literature that looked at cognitive behavioral therapy for AYA cancer survivors and found that the CBT intervention is only effective for AYAs when the treatment option is available and easily accessible, which is a kind of dull point, right? Which is like such an obvious point. But literature also points to that AYA cancer survivors are not as compliant to those interventions. So unless AYA cancer survivors are compliant and are fully engaged and cooperative with the available treatment and options, such as CBT, unless that happens, otherwise CBT remains a less than optimal intervention approach for adolescents and young adults who are diagnosed with cancer. If we look across the literature, there are essentially like two big components that I wanted to highlight here. One is the accessibility to CBT, and which is not prevalent at this stage, especially in the psychosocial oncology field. And then it's also speaking to the engagement piece of CBT, which is also less ideal, which I will elaborate just in a minute. So both sets of the requirement have not been successfully actualized in the real world practices of psychosocial oncology, especially for those who are supporting AYAs who are diagnosed with cancer. So first of all, I think it probably doesn't come, to a huge surprise to all of those of you who are listening. So CBT is often not easily available or accessible to AYAs with cancer. This really mimics the pattern of mental health professional workforce shortage nationally and internationally, and with studies that have consistently reported additional factors that contribute to the mental health workforce shortage in psychosocial oncology. So we know that in general, in the general field of mental health, there is a significant workforce shortage, and that workforce shortage is even more severe in the psychosocial oncology field, because not only you need someone who's specialized training in mental health intervention, but also there needs to be additional special training to the field of psychosocial oncology. And even for those National Cancer Institute designated comprehensive cancer centers where resources are relatively sufficient, such as Michigan Medicine, mental health resources are available, but the wait list is often very long, usually between 1 to 3 months, and not all providers are fully trained in evidence-based therapeutic interventions such as CBT, right? So if we think about not necessarily just being trained in the broad field of mental health, but also maybe receiving certification in CBT and really deliver CBT with high fidelity. And these kind of specially trained and educated providers are highly scarce in the field of psychosocial oncology, and fewer are supporting the AYA cancer population. So when we're facing the mental health workforce shortage, especially in AYE cancer, we then kind of veer into the advancement in the computer and mobile technology and to thinking about how technology-assisted cognitive behavioral therapy may be a potentially helpful or promising solution to reduce the access barriers facing many AYE cancer survivors in need of mental health support, but simply do not have access to those scarce resources. With that said, however, although tech-assisted CBTs, and I'm going to refer them as TCBTs for the remainder of the presentation, although TCBTs are highly promising in addressing access barriers, most of the existing technology-assisted options of CBT are academically oriented and text-heavy and does not necessarily engage the client effectively. And in addition to our knowledge, there exists no TCBT option that is specifically designed to meet the unique medical and psychosocial challenges that are confronting AYAs who are diagnosed with cancer, which resulted in a major gap in the AYA psycho-oncology literature, right? So the general theme of this slide really is there are technology-assisted CBTs, and we can maybe even deliver CBT through telehealth. But first of all, most of these modalities are pretty academic-oriented with a lot of texts and information, and so their levels of engagement is relatively low. And we know that working with adolescent and young adult, just that developmental stages, engagement is such a key issue. And second is that just based on our understanding of the literature, my team's understanding, we do not see a AYA and cancer-specific CBT that are out there that allows us to provide that added kind of tailored CBT intervention to meet their unique medical and psychosocial challenges and when delivering CBT, which is an evidence-based depression treatment option. So taken all together, our team identified 4 key areas of improvement that are needed to address depression among adolescents and young adults who are diagnosed with cancer. So first, it is important for us to integrate cancer-specific disease management and an educational component into TCBT treatment to ensure content relevance. Second, it is essential to be innovative to create fun and an engaging treatment content that are attractive and appealing to AYA cancer survivors, which is a younger population that is known to be difficult to engage in the therapeutic process. Third, it is also important to accommodate the visual material that are aesthetically appealing and developmentally attractive to the AYA population, including and especially those who are traditionally underserved, such as racial and ethnic minority and the sexual and gender minority adolescent and young adults who are diagnosed with cancer. And finally, it is critical to consider platform-based tailoring features that are relatively easy, flexible, and low cost to maximize individualized treatment options and to maximize the treatment uptake potential for larger scale dissemination. And the program that I wanted to share with you all today is a highly promising platform that simultaneously meet many of these areas, if not all of these areas that were mentioned in the previous slide. And the program is called Mind Your Total Health, also known as the MYTH program. So the MYTH program was named by a group of young adult cancer survivors who overwhelmingly expressed their preferences of not having the word cancer in the naming of the program. And many of them also found the acronym MYTH being somewhat cool or trendy to their population. And I've already heard, though, just for purpose of full transparency, the myth sounds cool to 25, 26 years old. But when I talk to 15, 16 years old, they would consider myth as something to their older generation, which I think really speaks to the dynamic and how the fast evolving nature of the developmental stage between that 15 to 39 age cohort, but also the heterogeneity within that age cohort. So the MYTH program is an AYA cancer-specific TCBT program that is tailored based on its parent program called Entertain Me Well, which was co-developed by Doctors Addie Weaver and Joe Himley. Both are from the University of Michigan School of Social Work with support from the National Institute of Mental Health. So the MYTH program inherited many strengths of its parent program, and it engages its user with a retrospective, engaging storyline, and it includes most sessions ending with a cliffhanger to boost the user compliance. And I will share more details on that exact point. And in addition to that, MYTH also utilizes platform-based tailoring features from Entertain Me Well and thoroughly modify those educational and motivational program panel for the developmental, medical, and psychosocial needs of AYA cancer survivors, which I will also elaborate just in a minute. But first and foremost, MYTH, I wanted to highlight that MYTH contains the core therapeutic elements of CBT interventions, which include cognitive restructuring, behavior activation, and problem solving. Although there are platform-based tailoring features available in MYTH that allows us to do some just-in-time tailoring to meet the unique needs of the AYA cancer population, those content related to CBT fidelity, including the order of delivering certain content, are in a sense locked, if you may, and cannot be easily changed so that the CBT treatment fidelity can be ensured and retained, regardless how a researcher or clinician wanted to tailor the program. And when tailoring the program for AYAs diagnosed with cancer, we conducted extensive stakeholder-centered interviews, including 15 AYA cancer survivors and 5 AYA oncology providers, asking for their input regarding the design, the aesthetic, and potential helpfulness of the content. And we made multiple iterations until we reached the current version of MYTH that I'm sharing with you today. So here are just some of the screenshots of the storyline that throughout the session, the Billy, if you can see my mouse moving around. So this is Billy, the blue balloon is Billy. Billy, retrospectively walks the users through her experience of overcoming depression. As briefly mentioned earlier, a notable innovation of the program includes a cliffhanger effect to encourage users to come back and find out what happened to Billy next, right? So for example, by the end of session 6, the storyline ended with Billy debating whether or not she would take up an offer to meet with her just reunited high school sweetheart Johnny at the dinner, but Billy still haven't heard back from the text that she sent him earlier. And that's the end of scene for that session. Naturally, the users would need to come back to session 7 to find out what happened next. Did Billy go? Did Billy not go? Did Billy receive the text or not, etc. So just to give you an example of how the cliffhanger effects are being utilized and amplified in the platform. And in addition, we made major tailoring of visual materials, as well as motivational quotes and examples throughout the sessions to better reflect the program's relevance to a population that has cancer and are relatively younger. So for example, as you can see, we were mindful in ensuring those materials are inclusive of different identities, being represented throughout the treatment sessions to the best of our abilities. And most importantly, we were very intentional in integrating cancer-related content into key CBT components, such as behavior activation, right? Just give you all a quick example on the lower left side of the on the slides. As you can see that the screenshot is a tailored educational panel that is doing a brainstorm exercise with AYA cancer survivors on potential activities for pleasurable activity as well as activities for achievement, which is kind of classic move in the traditional CBT intervention. As you can see, we included some low intensity physical activities, taking into account the likely physical limitation during and after an individual patient's cancer treatment, right? And we also suggested cancer care management as part of the activity for achievement to encourage users better healthcare management behavior, which is also integral and crucial to the general wellness of an individual cancer patient's disease management that often intersects with the manifestation of their mental health, and specifically here in the platform with their depression symptoms. And just to underscore some of the full potentials of the program, right? So it can be easily achieved for us to create a more individualized platform. Materials such as an educational panel specifically designed for AYA serving in the military with a diagnosis of lymphoma, right? So if we think about, and if we think about when we're tailoring this to a unique sub-unique population, right? So it's not just the AYA population, but what about the AYA patients who have a specific diagnosis of lymphoma or a specific diagnosis of sarcoma, but also having other unique identities that they carry. So these tailoring features, essentially we call them tailoring panels, give us a lot of those flexibilities that allows us to engaging those more individualized tailoring, which again goes back to the evidence-based practice framework that we're all quite familiar with as social workers. All right, so for the remainder of the session, I would like just to share with you a pilot study that we recently completed, and we're grateful to receive grant, the psychosocial grant from Julius Legacy of Hope Hero Fund through the Symbotrix Foundation to evaluate the feasibility and preliminary efficacy of the MYTH program in reducing AYA cancer survivors' depressive symptoms in a pilot randomized control trial. So primarily we used in a pilot RCT, we used a clinic-based recruitment strategy at Michigan Medicine in conjunction with community-based self-referral. We recruited participants between the age of 15 to 26-year-old with a current diagnosis and an experienced moderate or greater depression. As many of you probably have already noticed that in this pilot, we included only 15 to 26 years old, whereas the AYA age range is between 15 to 39 years old. So there's always that tension and struggle when it comes to the kind of the clinical practice and the research that are informed by clinical practice to trying to find the best age range when we're tailoring a mental health intervention, right? So for this study in particular, we really focus on 15 to 26 years old, which is a subgroup of the NCI definition. And one of the main reasons is that we wanted to adapt a smaller age range in the trials so that it is important for us to have a more focused tailoring and an effort towards that developmental stages. So a participant can either receive active cancer treatment or with curative intent, or within 5 years of post-treatment survivorship to be participating in the study. And our study exclusion criteria include if a participant is receiving an end-of-life care or currently experiencing acute mental health conditions. Here we are referring to active psychotic symptoms or with an elevated level of self-harm, meaning if an individual with a active suicidal ideation with within a plan or greater severity, then that participant would be excluded for participation. So over an 8-month period between September 2020 and April 2021, our team contacted 49 potentially eligible participants, and 20 of these participants were not interested in the study for reasons including being self-identified as not depressed or not in need of depression treatment at the time. Others reported a not interested in computer-based program due to the overexposure to computer screening during the COVID-19 pandemic, and some prefer to wait for an in-person clinician available, right? So here, I think even just by looking at our study recruitment flow chart, it really speaks to a couple of things. First, the COVID-19 really, the Zoom fatigue really burned a lot of people out. We know historically that the AYA population would much rather to engage in computer-based treatment versus in person, because that's their platform of comfort, and they often find that in-person interaction with an authority figure sometimes can be awkward and brings discomfort. But during the peak of the COVID, as you can tell during our study, which is September 2020 to April 2021, they were actually so fatigued out by almost everything virtual, they kind of went back circle to wanted to more in-person contact, which is an interesting just side note that I constantly share with my team members. So in addition, for this interest, there were 12 potential participants who did not meet the study inclusion criteria, including 9 reported a PHQ-9 score lower than or equal to 9, which means mild or no depression severity at the time. And 2 participants were receiving end-of-life care at the time. And 1 participant reported history of suicide attempt over the past 2 months and currently is still having elevated risk. So consequently, the pilot randomized control trial had 17 participants being randomized into the experiment arm or the control arm. So participants in the treatment arm, which is our MYTH program arm, received the MYTH program, which is an individual-based 8-session TCBT delivered on a weekly basis. Study participants were instructed to complete their computer portion of the session on a weekly basis, but had up to 10 weeks to complete all sessions. So there are some flexibility there if they missed a week, etc. And then upon the completion of each individual session, so that's every week, a master's level trained research assistant would follow up with the participant through a 5 to 10 minute check-in phone call to reinforce session content and to link the specific session content with each patient's cancer management, right? So sometimes we may talk about certain depression care using examples through the tailored slides about their cancer care. So the coach or the research assistant would highlight some of these content during the 5 to 10 minutes follow-up call. All research assistants were instructed not to provide additional therapy, and we, when permitted by the patient, we did record some of the follow-up Zoom calls, and I listened to some of those sessions just to ensure treatment fidelity. The reason we included a brief clinical follow-up call with a human coach was based on the best practice of technology-assisted interventions from the literature that says, it is most effective to briefly involve a human clinician when delivering a computer-based program so that the participants would, or the patient would still remain engaged, but it doesn't really take that much of a time of the provider. Right, so the brevity of the contact with the human coach is key here because it would not excessively strain the mental health workforce challenges that are facing the field, but simultaneously to maximize or to strengthen the engagement with the participants or with the patients. And using a very similar and almost identical structure in the control condition, participants in the control arm received an existing TCBT platform, which is called Beating the Blue, which is a commercialized evidence-based depression treatment for the general population. Key differences between the MYTH program and the control arm Beating the Blue, including that Beating the Blue is rather text heavy and academically oriented, and it is a generic version of CBT for depression without specific tailoring for cancer and for AYAs, right? So as you can see, what we're really trying to look at is we wanted to make sure that in terms of the dosage, the formality, and the attention that the participants get in the treatment group and the control group are very similar and almost identical with each other. And we wanted to see if making CBT more fun and engaging, making it cancer specific and an AYA relevant, right? These specific tailoring and a component, if the difference between the two groups, because of these specific ingredients that we're testing here, these two groups are really showing any significant differences. So other than kind of the engagement piece, the AYA piece, the treatment and intensity and frequency are almost identical between the two groups, and the research assistants in the control arm used the same protocol as the one used in the experimental arm to ensure study rigor, which is to rule out any potential between group difference that are caused by different follow-up protocols. So we evaluated the feasibility, the acceptability, and the participants' clinical improvement using well-established and psychometrically validated scales. So given the time limit and just the purpose of this presentation, so I will only just highlight some of the key findings here, right? So first of all, 80% of the participants in the experimental arm achieved the feasibility endpoint, which means that 80% of the participants in the experimental group completed at least 8 out of 8 sessions, completed at least 6 out of 8 sessions of MYTH, versus in the control condition, 71.4% of the participants achieved the feasibility endpoint. There are 2 pieces of more nuanced data that I would like to share with you that kind of speaks to the difference between in terms of the feasibility and acceptability between the MYTH program and the Beating the Blue. So first, out of the 6 out of the 8 participants in the treatment arm who achieved the feasibility point, and all 6 of them completed all 8 sessions. So meaning if a participant in the treatment group reached the feasibility endpoint, they actually completed all 8 sessions, whereas only 2 participants in the control arm that reached the feasibility endpoint that completed all 8 sessions, which really speaks to that for participants who kind of stay with the program, as participants receiving a MYTH intervention are more likely to complete the entire dose of the program, versus for those in the control condition, they're less likely to complete the entire dose, which are 8 sessions of the program. And second is that 1 participant indicated the intervention not being helpful in the control condition as the reason for dropout, whereas no one in the experimental arm cited that reason for dropout. So the reason that participants dropped out in the experimental for the MYTH condition was really disease specific, right? So 1 participant talked about increased pain caused by changes in that patient's cancer treatment. So the patient is unable to stay in the program. And then a second patient simply is just no longer interested in participating. But upon exit interview, that patient actually think the platform was good, but just not, the patient is no longer interested in participating in the study. So participants in both groups reported a statistically significant reduction in depressive symptoms measured by the Patient Health Questionnaire 9 item. And then it's worth noting that The between group effect size was large in its magnitude, meaning participants receiving the myth intervention reported significantly and clinically greater reduction in depressive symptoms than their counterparts in the control condition. Additionally, it was also encouraging for us to observe that not only for depression, but participants in the experimental arm also reported a statistically significant in anxiety as measured by the Generalized Anxiety Disorder 7-item scale, the GAD-7. And the reduction was statistically non-significant for those who were in the control condition, but only significant for participants in the treatment condition. Although there may be reasons that can lead to such finding, such as statistical power, but we do consider this finding highly promising given depression and anxiety are often highly comorbid among AYAs diagnosed with cancer. So it was really, really promising and encouraging for us to see that for participants receiving the MYTH program, not only we see a significant and clinically meaningful reduction in depression, but also we see a significant reduction in their anxiety, which is not seen in the control condition. So even though we did not conduct any formal in-depth qualitative follow-up interviews with study participants for a variety of reasons, and I can share more during the Q&A, we did learn a lot of from the study participants about the strengths and weaknesses of the MYTH program through brief exit interviews, which occurred by the end of their last session. So first of all, participants in the experimental arm were overwhelmingly positive about the cliffhanger effect. And many of them found the strategy effective and it encouraged their compliance to all sessions, right? So we have participants actually sharing that, you know, especially for the second or the third sessions, that they were almost giving up, but because that they wanted to figure out what happened to Billy, so they stayed on, right? So that was one of the main reasons that kept them keep going to complete the entire treatment program. And as we expected, the longer that they stay with the program, we see a strong connection with Billy, the main character, build up. So they're more likely to stay further along, etc. So their builds, you know, they're seeing the cliffhanger effect. And there were, for those of you, well, I don't know how many of you will actually get a chance to see the Entertain You Well program, but spoiler alert, they were very glad that the story ended with a happy ending, that Billy and her high school sweetheart had a happy ending. So, you know, a lot of them were very happy and commented on, you know, that their life often sucks with cancer and they much appreciated a happy ending and then put a smile on their face. Several participants also considered MYTH as a valuable mental health treatment option that can be embedded or integrated into their cancer care. Especially many participants talked about when they're doing outpatient chemo, when they're doing infusion, then when they don't have other things to do, or they, you know, they were just they're killing time. They would much, you know, they all commented on that MYTH can potentially be a very effective and innovative approach for them to look at, to go over, etc. And all participants appreciated the privacy and the safety of receiving CBT remotely and the destigmatizing nature of receiving TCBT for their mental health needs, right? So a lot of the active patients who are currently receiving infusion or chemo or in the process of BMT, the bone marrow transplant, they all commented on that they wanted to, you know, to address some of their mental health issues, but they don't want to in a public space where they can see that they are talking to a psychologist or to a clinical social worker. They would much rather to do something on their computer or their laptop. So they commented a lot on the destigmatizing feature of the platform. And finally, many participants praised the tailored content being medically relevant to their experiences and aesthetically attractive to them, right? So they liked some of our image tailoring, but an interesting thing kicks in that I think our teams and our stakeholders kind of interview in terms of tailoring the aesthetics of the platform. It seems that it's more appealing to the older generation, meaning the 22 to 25 years old, whereas for the younger ones, they were like, oh, well, the picture can be better. There are cooler visuals, right? So again, and it speaks to both the strength, but also areas for improvement, which is maybe we need even versions specifically for a more kind of defined or smaller age range between 15 to 17 years old, 18 to 22 years old, 23 to 25 years old, et cetera, et cetera. So my last slides, and then we'll get a Q&A. So there are a couple of areas of improvement that has been identified both by AYA cancer survivors, by study participants, and are kind of already known by our team. The first and foremost is the storyline improvement. So currently, I'm intentionally trying to be vague, is that the main character, Billy, in the current version, Billy is not a cancer survivor, right? So the main storyline does not contain Billy's experience overcoming comorbid depression and cancer, despite many of other platform-based tailoring, right? So unanimously, all the interviewed participants wanted Billy to speak to her cancer experience in the next iterations and to talk more about how cancer intersects with her depression and other kind of mental health feelings, such as the fear of reoccurrence, the fear of death, and many other common mental health disorders that are often intersects with depression, which is definitely a next step that our team are actively seeking funding and hoping to achieve soon. It was also interesting for me to know that there are some older AYA patients, when they commented on Billy being the balloon, they just, only a couple of them, not the majority, but they found Billy the balloon look being a bit childish, and are more fitting or more appropriate for those who are younger. So the older cohort now refers to that the balloon character are more appropriate or maybe appealing to the younger generation, the 15 to 17 years old, even though all of them acknowledged that they felt connected with Billy, but some of them commented on they would appreciate a maybe more humanoid version of the character, again, which goes back to kind of the diverse and how dynamic this age group can be and how heterogeneous this population is. So the current MYTH program has a separate paper and pencil workbook that for CBT homework, and overwhelmingly and not surprisingly, AYAs wish that workbook can be integrated into their cell phone via a mobile app, ideally to be connected to their calendars. So when they're designing or when they're tracking their daily activities, when they do their daily walking for activities for pleasure or activities for achievement, they can just document that in the phone and link that within the website, which I think is, again, is a very nice suggestion, but requires additional resources that we need to use for us to be able to implement these challenges and suggestions. And finally, participants reported that they would prefer that their assessment results and TCBT experiences can be shared with their providers, especially for oncological providers, for somewhat and interestingly to opposite reasons, right? So one of the group of AYAs, they wanted to share their assessment results and their TCBT experience with their oncologists so that they can talk to their providers about their mental health, because currently and unfortunately, pediatric oncologists or medical oncologists, depending on where the patients are receiving care, primarily see the patients like on a 15 to 20-minute increments as routine practice, right? So it's always about symptom management, thinking about the disease progressions and medications and treatment, and then done. So a lot of my oncologist friend in Michigan Medicine and across the countries wanted to engage in some of those mental health conversations, but they often felt kind of out of their depth in terms of where to start, how to start, and even with some of their patients who wanted to share. So, right, so sharing the assessment results and the TCBT experience may facilitate some of those experiences. So that is one big theme of why they wanted the mental health to be shared with their oncologists. And then interestingly, a second group of feedback talked about they wanted their TCBT and their assessment results to be shared with their oncologists for the very reason that so AYAs do not need to spend too much time talking to their providers about their depression. So kind of, I think one of my friend and also a patient said, right? So they're just like, I'm taking care of my depression and I just don't want to talk. I want to avoid that awkwardness talking to my oncologist about how I'm feeling depressed, about my relationship, about my sexuality. I'm taking care of that. So I don't want that take up any of the time where I wanted to discuss my own oncological care with my provider, right? So it was interesting for our team to see that even though it's the same ending, that we wanted to share that with their oncological team, but for very different reasons, which is just something fascinating for us to learn that. So I think that is it. I would like to thank you for all of your time listening, and I'm happy to take questions.
Yeah, and we do have some questions and comments that came in. I'm just going to go in order based on when they were submitted. So the first one, I think this is referencing back to the beginning, that poll question when you were asking factors that are related to cancer. So this person asked, what about genetics and family history?
That's an excellent point. So these are, so if the question is about our genetics and family histories are also salient risk factors or protective factors, yes, right? So I did only allude to that, but not explicitly talk about this. So we often kind of group those big categories into what we call the genetic predisposition, right? So there has been rising evidence, though not conclusive, that certain populations coming from certain family trees with certain family histories are more likely or have the genetic predisposition to having certain types of cancer when other factors are the same. I think the major thinking, to my knowledge of the literature, is that social determinants of health, often referring to those psychosocial factors, are often exacerbating factors, meaning, well, you may have that genetic predisposition, but if you are in pretty well positioned with relatively higher socioeconomic status and good lifestyles, then you are still having a relatively lower risk versus with the same genetic predisposition. If you have more social determinants of health risk factors, then you are more likely to have diagnosis with cancer. I think that's an excellent point.
Yeah, that's actually very interesting. So lots of comments about the age group. One person commented on, it's an interesting redefinition of young adult. What are the other categories and corresponding age ranges? There was also, in relation to that same comment, how large of a group that it is. So it seems like it's a very large spectrum of life experiences across such a large age range, kind of that whole thing.
Sure. Yeah, no, I think that's an excellent point, right? So I just have to comment this. Love the Michigan Muck collection. Yes. And I think that's an excellent point. And these are excellent points, right? So the 15 to 39 years old, I don't know the full picture, but I want to say that it is more of a historical / empirical cohort that we're defining. So essentially, I believe the National Cancer Institute looked at the data of the kind of the cancer incidence and treatment progress, and they found that that 15 to 39-year age gap were just lagged behind, right? So that has kind of caused them, I don't think arbitrary is the right word, but maybe primarily using an empirical driven approach, they took out that scoop of 15 to 39 years old. So the Australian, I think Australia uses a different age range. I want to say they use 20, I want to say they use 18 to 35-ish. I'm not positive on this one. I need to go back to the literature and take a closer look. So it is, I guess my point here is that it maybe it wasn't starting with a kind of theoretical grounding in defining the AY age range, right? And then to the other comment that Emma was referring to, you're exactly right that it's such a wide cohort. So our latest data found that there are over 650,000 survivors of AYA cancer that are in the United States back in 2021, which is last year. And we can tell that because the AYA survival gap is catching up, so that population, we only expect that population to grow exponentially in the next couple of decades.
Did you track outcomes 6 or 12 months after the treatment program ended?
We did not. I think that's such an important point, right? So we did not, for a couple of clear and unfortunate reasons. One thing is that the study was conducted during COVID, and the cancer center scrutinized any studies that are occurring during COVID. So for us to keep the study open and then to add more kind of follow-up tracking point, and we need to change our protocol. And because it's not a large enough cohort for us to track, so we unfortunately have to close the study protocol from an IRB standpoint. And for that reason, we were unable to continue to track. But really, my goal is to find the next, find funding for the next level, larger clinical trial that would allow us to look at the long-term impact, ideally 6 months, and if in my dream 12 months if that's possible. But we know that this population also has a very high attrition rate when it comes to clinical trial enrollment. That's of course inclusive of behavior trials.
It looks like we have another question in follow-up to the program. Did you look at race and or SES when choosing your participants?
We did. So we were with the, so let me say this. We did look at race. We did not look at SES for the reason that our statistical analysis, because of the small sample size, our statistical analysis does not allow us to look at these factors as potential influencing factors. We know they are theoretically and conceptually, but from a statistical standpoint, and because of the small sample size and because we were unable to conduct those analyses, so we took a minimalistic approach. That is, if we're not going to use the data, we won't collect that data. So the SES data we should be able to get that from part of their electronic medical record if disclosed, but we simply just did not disclose, we did not extract that data. And for the race and ethnicity, we were pretty fortunate with the pilot trial that I believe we had out of the 17 participants enrolled and randomized, we have, I want to say 3 to 4 Black Americans, 3 to 4 APIs, and maybe 1 Hispanic American, and the remainder are non-Hispanic white Americans. knowing the catchment area and in our large population in Michigan medicine and in general in the state of Michigan, when it comes to the cancer population, I do think that the study is pretty well represented. One thing that we are making active effort, which is to collaborate with the University of Chicago Cancer Center so that our future research can be more inclusive of those from underrepresented backgrounds.
Great. A couple comments. They're not really questions, they're just comments, and they want you to respond to them. Regarding to kind of the impersonalness-ish of the, I think entertain me well is what they're talking about. So this person said, as an old line social worker practicing for close to half a century, I find the lack of a therapeutic relationship and the severe impersonality of this to be hair raising. And then the other person said the same thing. What about the therapeutic relationship?
Mm-hmm. So I think, these are always kind of debated topics that in the field of telemental health, but more so, I think, in computer-based interventions, right? So I personally, being a clinician, I struggle a lot with how the computer may serve or may in one way or another replace, for the lack of a better word, the interpersonal therapeutic relationship that are most effectively to be built during in-person communication. So there's a couple of thinkings behind that. So first of all, I think it's fair to argue that most of the computer-based CBT platforms or literature are not conceptualizing TCBT to be a replacement of in-person therapy. So that is kind of that general consensus. What it effectively does, though, is that it offers that first layer of treatment that for those patients who may, in need of mental health interventions, but may just become better with some kind of gentle nudge in terms of the help, right? So not necessarily with that, not necessarily needing that full dose of therapeutic push for them to get better. So with some self-management, with engage with a program, computer-delivered program, and maybe with a regular human check-in to see if that works, right? So if as a first line of treatment, if this fails, then the next treatment and option can be the in-person, more classic schools of interpersonal therapy. So I think that is kind of the stepped care model is usually how most of the TCBT researchers are conceptualizing the utility of TCBT. So that is kind of the first thing that I want to talk about. The second thing has to do with the idea of Billy. I'm not arguing that this version of Billy can replace that therapeutic relationship. But, right, so if we all think about that as a regular audience, right, we watch Netflix, we watch a lot of shows that we do find personal connections with characters in multimedia, right? So whether or not it's a TikTok, it's a YouTube, it's Instagram, right? So you do get attached one way or another. So we are kind of just creating the existence of Billy being entertaining, engaging, and a character that had similar experiences that the users are experiencing or had experienced, hoping that there's that level of connection. Again, I wanted to emphasize, personally, I don't think it can be a replacement of the good old therapist, client, therapeutic dyad, that therapeutic relationship, but I think it can be maybe a proxy or a minimized proxy version of that, which allows the person still to have some level of connections. And that kind of also ties back to my third point, which is, again, emphasizes what the literature is reflecting, which is the involvement of a real human therapist is critical here, so that they would still having some of connection, not just with a computer or an animated character, but also with a real provider, even though that level of connection understandably would not be as strong as with a full-time in-person mental health clinician.
Yeah, I think that's a great answer. And I feel like, Addie talks about it a lot. The main goal with Entertain Me Well is accessibility,
Mhm.
and just having that virtual component, it makes it so much more accessible. Um, and on the same topic, what will the future of the program entail? Will it be tweaked and continued?
Yeah, no, so that is one of my primary research area that I'm working on. I was fortunate enough to start this, to starting my junior career at Michigan with Joe Himlin and Addie Weaver at the Tider Lab. So our next goal is that we're actually, we just had a meeting with a investigator from the National Cancer Institute. They are hoping to look for opportunities to take up the current myth version and try to do more open pilot data, trying to collect more preliminary data. The next step would really be we're going to scale up. So primarily hoping to get either a development grant so that it would allow us to create a cancer specific storyline, with the same idea, same engagement, but with much more tailored and specific AYA and cancer-ness, if you may, into the platform, and then to test that in a larger multi-center randomized control trial. So that's really kind of the short / the long-term goal of this line of my research.
Very cool. Was there a difference in your pilot program and the results between AYA undergoing active cancer treatment and those in remission? It's a really good question.
That's an excellent question. Yes. So I do want to say, right, so it's always a struggle in the research field, right, for us to think about, even from a proposal standpoint, like, do we want to include both patients and survivor? Do we want to include only post-treatment survivors versus only those who are in the active treatment? Understandably, their needs are very different, right? So what we observe is that for those individuals who are in the post-treatment phase, their depressions when they enter the study tend to be more chronic, if that makes sense, versus for those active patients, their depression are more situational. So what we see a lot in our study, that for patients who are active patients, right, so their depression are often primarily situational. That is, oh, if my doctor changes my treatment, I'm feeling terrible for the past 2 weeks, then depression are going to spike high, especially depending on what symptoms that they're experiencing. Versus for those post-treatment survivors, they often come in with not necessarily a less severe depression, but their depression are more chronic. So they've been troubled by the depression for a while, and they're seeking different ways of addressing that. I hope that just, in a brief way answers your question, and I can further elaborate it if helpful.
We had another one just pop in. Is there also potential to open things up internationally and in different languages? Since it is a program that is technology based, I could see lots of potential for this.
That is such an excellent point, right? So the short answer, of course, yes. The longer answer is that yes, with a lot of logistics and IPs behind, and IRB's coordination behind, et cetera, right? So, because if you think about the platform, it's also a place where that houses patients' information, right? For us to protect different versions, like different platforms of patients' informations, and also when we're creating different languages, there's also the internet access barriers, right? So some countries, maybe the bandwidth are not available. Other countries may even have because depending on which country you're dialing from, you may have a poor internet connection or not even possible to access versus easy accessibility, right? So there is a lot of logistics and the planning behind that, and probably we would need a lot of coordinations from both, the original country and from folks here at to coordinate to make that happen. So yes, but with a lot of efforts.
Yeah, I would think there would be some legal hoops to go through.
Correct.
As well.
Yes.
Yeah. In addition to the post-treatment phase, do you see trialing this in a post 5-year treatment population?
Yes. So after five, right? So we look at the 5-year survival rate is that the reoccurrence and the death rate are significantly reduced once you make that 5-year benchmark, significantly in relative to, of course, the within the 5 years, so not saying that you are cancer free. So after 5 years, usually the AY groups or the general cancer populations are or just kind of, they're excited, they're eager to move on to their regular lives. So in general, they're okay. So I would say in that phase, their depression may be less relevant to their cancer. That's just based on my research experience and clinical experiences versus those within 5 years, because they are still like constantly watching for cancer coming back, so with the ups and downs, different health checks, etc. So yes, but I think the focus then and the kind of the design and the conceptualization of the platform will be slightly different just for that reason. Even though I do want to say the AY population had a lot of long-term and latent side effects as a result of their cancer treatment, which is a common theme for the post 5-year survivorship target. Exactly, I see a lot of your comments about that.
Yeah, so we got through just about all the questions. Some really great comments in there, just commending you and now on your work and the very informative presentation. I'm not sure if any of you joined us last year when Anal presented with a few other of his colleagues on this topic. It was really great to get to hear more from you. Anal, I really enjoyed it, learned a lot. So yeah, thank you everyone for joining us. Again, special thank you to you and now for joining me once again for a webinar. I just want to remind everyone that if you are getting CEs today, please allow our continuing education office a couple weeks to get you those evaluation forms. They are going through a lot of different webinars, including all 5 that I am hosting the next 2 days. If you have any questions on that, please contact them. You should see their email address on the screen. And the last little thing I'm going to remind you all about, we will be having our closing reception tomorrow at 3:45. And the goal of that is to just debrief all of these topics. It's very informal. I'm just going to talk about what we learned, any final questions folks have, and really talk about how social work has changed and transformed throughout the pandemic. So again, thank you, everyone. I hope you have a wonderful rest of your day. If you're in Michigan, enjoy the sunny weather. Thanks, Anau.
Bye, y'all.